So I call the talk Cannabis Conundrums, but I make emphasis of saying that science and reason matter, so that's sort of a prevailing theme here. The attestations, though, are kind of fascinating from that last third one from the bottom that you see about using things that are off-label. Well, all Schedule I drugs are off-label by definition, then everything I say is being mentioned that way, and that's my disclaimer. So in terms of the ABIM requisites for having objectives, this is a huge subject. It's impossible to cover in this short time frame, and whether through the panel or after, please find me for that purpose. So I'd like to start off with differentiating some of the ways that Florida now is different than the federal guidelines on this. Assess specifically the efficacy as limited as it is for specific indications showing evidence-based data, and of course its risk-benefit for therapeutic use. The trick there is there's really not as much out there. So that's where this third objective, I think, is really the highlight of today's talk. If you want to understand that limited evidence-based data, it has to be understood in the context of a biological context. So we'll be spending a fair amount of time to try to describe how some diseases as disparate, say, as Crohn's disease and epilepsy, can all potentially see therapeutic benefits through manipulating this particular receptor system. So the politics in this are obvious, and the AMA today, this is what its guidelines are and stated mission: to bring together physicians and communities to improve the nation's health. But in 1937, there was the first law of cannabis prohibition, and at that point, it probably wasn't realized quite the extent that it might undermine future research and education. But the AMA did speak out about this, and Dr. Woodward publicly did not dispel any impression that either the AMA or enlightened medical opinions sponsored those particular laws' politicized rationale. So even back then, they realized that there's probably an unknown quantity involved that might have important uses in medicine and psychology. And so it's hit Florida. It's hit the United States, many more states compared to 2 years ago when I presented last. Now there are 33 that have legal medical programs. But also now 11 states, including DC now, have recreational programs which are sort of blindly flying because the medical's not well known enough yet to truly justify recreational use without those side effects and potential poor outcomes, which now will be more able to be monitored than it was perhaps a few years ago. Florida now has a different law, and this became into effect just last Monday. And I don't know if you're aware of it, but non-opioid alternatives now are a requirement to discuss with patients as alternatives, again, to the opioids. And that's where the discussion of cannabis might be coming to your office sooner than you might realize. The reason that things are also different now is I'd like to present today's talk in the context of the consequences, beneficial and drawbacks, to public health. And the very notable thing happened this past year. Drug abuse, you see the column all the way on the right that is going up. This is a chart from back in 2004. Now has surpassed motor vehicle accidents in terms of a frequent cause of preventable accidental death. That's huge. And of course, I've circled tobacco, smoking, and alcohol because, as I'll cover a bit later in the talk, they're inextricably connected to the subject of cannabis. So we look for guidance, and the nation's top docs, going back to 1970, which is when the Controlled Substance Act defined what would be a prohibited substance, surgeon generals have been for, against, or most recently, the last several, not clearly for or against. And so it begs to ask, what's a poor physician to try to do without that kind of guidance? So I'd suggest to you that one way to start might be from an ethical platform. And most ethical questions such as this: should a physician provide compassion to cannabis while under its federal prohibition? In this issue, you'd think we'd be approaching things from a medical legal perspective. That hasn't been necessarily fruitful, even though the AMA does have a disposition on this, saying that a physician shall respect the law and also recognize the responsibility to seek changes in those requirements that are contrary to the best interests of the patient. The reason it hasn't been that effective is you generally hold two licenses. One is your state license that may entitle you to see a patient for the purpose of that, but you have another license, your federal DEA license, which still in conflict with this would not be necessarily well taken if someone were to see patients in that context. And there's a certain fear of what might happen with my DEA license should I see someone. And so for that reason, most mainstream docs are not willing at any possibility of sacrificing that DA license to see patients in this space. There are over 2,000 doctors in Florida who now have passed what requirements the state has for seeing patients, but probably a fraction of those are actually seeing patients actively. So medical legal ethics from this platform hasn't necessarily been effective, probably because we didn't know what questions to ask, which is exactly why bioethics evolved. Bioethics is a different field of ethics that largely after World War II had to answer questions we didn't know to ask before, nuclear energy, things like that. It actually took that kind of a conversation a little more than a decade ago to have the acceptance of stem cells that originally had more limited research lines allowed. But with the understanding of the supporting science and the benefits that can derive from it, think of all the wonders that stem cell research now and practical application have presented over the last decade. So in a bioethical situation, it helps to come up with a disposition that in certain cases is a compromise between opposing sides. I find that to propose something in a bioethical way that would be an irrefutable point of view that neither pro or against, in terms of advocating either for or against, could refute, may be a more sensible way to approach it in an effort to do the right thing. So seeking the relief from intolerable physical, psychological, or spiritual symptoms of disease is actually a natural instinct. Animals do it, people do it, and it contributes to therapeutic substance use. And yet the treatment of those intolerable symptoms is the noble task that society bestows upon its healers to provide humane relief. That to me makes sense. This appeared 2 years ago, and this doesn't make sense because this lady who could have been my mom is asking someone who's got an FMA, and I've got a pin here, a badge on, about giving some miracle marijuana, and he's worried about unintended consequences instead, knee-jerk response to OxyContin. And of course, we know from 2016's publication through the CDC that we need to look at different ways of treating. So I come to you from the world of anesthesiology, and anesthesiologists actually were involved with the creation of National Doctors Day. And I want to remind you of the importance of surgical anesthesia that actually began as a recreational use substance. They were called ether frolics in the 19th century, very well documented. And it took an observational initiative from a Dr. Crawford Long in Georgia, who found that the patients who were seemingly encountering painful things, playing, falling, banging something on a dramatic fall, didn't recall and didn't seem to say that it was painful. That's a eureka moment that made, in essence, all surgical specialties in the advance of modern medicine as we know now, because before that you couldn't look into the body other than post-mortem. So getting into this particular plant that's been used for millennia therapeutically, cannabis has been grouped into a category through the FDA, which is there to, of course, look at the safety and efficacy of use versus abuse, compared to the DEA, which is looking at the risks and benefits from a prohibited or controlled status. And the scheduling for cannabis is Schedule 1, and I wanted to remind you of what these definitions are, because this does make a difference, is there are 3 criteria, key criteria. One is that it has a high potential for abuse, and that's a relative term. The second is it has no currently accepted medical use in treatment in the United States. That's what's being challenged vigorously now. And the third is that there's a lack of accepted safety under medical supervision, which has been de facto next to impossible to do because of its controlled nature. So cannabis is not the only botanical medicine in this case that we know has certain challenges. Certainly the opiates have been derived and has been used again for thousands of years, and cocaine is Schedule 2. Some people think it's 1, it's not. It's used commonly in ear, nose, and throat surgery because it's a local anesthetic that has vasoconstrictive properties. Then there's this, it's not a botanical medicine per se, it's part of culture, but by far, tobacco is the leading cause of preventable death globally. And then, of course, you have certain other plant-derived substances which are known to produce endorphins, make people feel good. Imagine if chocolate and coffee were outlawed. So plants have played with the skeletal molecules that derive many of the things we use today. So this next section of slides, just 2 or 3, and there'll be a handout that you're welcome to get after I'm finished that will emphasize what's currently known, is largely derived from a 2017 study through the National Academies of Sciences, Engineering, and Medicine. And that study found the following. Cannabis, in terms of the middle row there for THC, we'll talk a little more about THC, but in limited capacity here, the best evidence is for chemotherapy-induced nausea and vomiting, for chronic pain, and that's the key one for Florida's laws now, and multiple sclerosis muscle spasms. The reason I'm mentioning chronic pain there is, remember, Florida's laws are based on a series of diagnoses that fall within an acceptable parameter as defined, that those patients having those diagnoses should be able to access cannabis. Well, chronic pain is not a diagnosis, it's a symptom of many diagnoses and therefore highly exploitable. So I wanted to point out one thing about the first-line treatment. As of 2019, it is not a first-line treatment. It is not meant to be an alternative in that sense for the advances that Western medicine has made, both diagnostically and therapeutically, but as a complementary medicine. That's where it seems to find a niche space, otherwise known also as integrative medicine. On the handout card that I'm happy to share with you when we're finished is also the existing formulary that in 2019 is categorized from the column on the right as the scheduling. And if you'll notice all the way on the bottom right, just last year, the rescheduling of cannabidiol, CBD, which is not a psychotropic molecule like THC, but one that's getting a lot of attention now, was recently rescheduled to Schedule 5 through one particular drug manufacturer's product. I want to tell you that even though you'll see that product everywhere around town, that technically the DEA did give a disposition on this, that the only formulary having CBD would be that produced from a company named GW Pharma, specifically for children with intractable epilepsy from two particular diagnoses. Doesn't mean it couldn't be used again off-label. The point I'm bringing up with Schedule 5 is they could have easily just moved it incrementally to Schedule 2. Schedule 5 is sort of a testament to the safety profile of CBD. So what are the contraindications then? And there's really three general ones that I'd like you to know about. First is pregnancy, and that's because not so much on the mother, but the developing brain, those initial cells. We don't know very much about it. It's a tough group to work with. So these are all relative contraindications, but you'll find that in states where it's legal, in particular Colorado, that 70% of the, as they call it, bud tenders, or the people behind the desk who are offering it to patients when giving it to patients for nausea and vomiting associated with first trimester pregnancy, don't necessarily say go see your doctor about it. They say we recommend this. A second one would be individuals with pre-existing heart disease. Cannabinoids, in particular THC, especially with novice users, can increase heart rate dramatically. And in those patients with perhaps a marginal cardiovascular system, that could have negative sequelae. And then finally, people with pre-existing or genetic predispositions actually also to mental health disorders. So where this really comes to light, though, are with kids. They still have developing brains. And children, in the last, what study goes back to the early 90s, have been looked at in terms of trends. How is alcohol being used or abused by youth? And then also tobacco. Well, all of the efforts to bring use of alcohol and cigarettes to the attention has actually helped the rate decline. On the other hand, since cannabis has been medically legal in certain states, there's been a general thought or an acceptance that, gee, well, if it's legal, it must be a real medicine. It's probably okay to use. So you see that cannabis rate is actually ticking up among youth. The NIH has published and had some excellent symposiums where it talks about what we really know now versus what we need to know. Obviously, the cognitive impairment involved is classic. It is not a performance enhancer. And yet, there are some frequent subtle things that can be followed longitudinally, and there is a lack of longitudinal studies in this space, perhaps with one notable one from Dunedin study. This is not Dunedin, Florida, it's Dunedin in New Zealand. And for 30 years, they followed children who started young at 15 years old, and then over the subsequent 20 years measured IQ. Now, those students or those children who started young and persisted and didn't stop showed a demonstrable drop of IQ. Not who stopped or started in later years, but this specific subset showed an 8-point IQ loss. So when I tell that to some people, they think, oh, well, 8 points, that's not so bad. 100 starts at 100, goes down to 92. That's still a low A, right? That's not IQ. In a bell-shaped curve, I want to tell you that 8 points to being 92 is the 29th percentile. So not knowing the potential of your child, my advice is try not to lead them with that temptation in the event that they could become potentially the 29th sharpest pencil in a box of 100. So what's needed then really are longitudinal studies where we have a way to follow from childhood through adulthood for those things. That's really all we know, in essence, about what it's good for and what's been done. And so I want to shift now into looking at something that came to my attention in 2013. This is an NIH paper, and the two authors on the top, it's hard to read, Pal Packer and George Kunos, are not just PhD researchers who know what cannabis might do to a lab rat, they're MD PhD researchers. And they made this statement in this summary paper: modulating the endocannabinoid system activity may have therapeutic potential in almost all diseases affecting humans. All diseases affecting humans. So you go, what? How could that be? As an anesthesiologist, I've been a receptor-specific pharmacist and physiologist essentially my whole career, and it just didn't make sense to me. So I dove deeper in, and the subtitle of this paper, in fact, is the Targeting the Endocannabinoid System. So what I'm going to present to you in the next few minutes, I'd like you not to think of in the context of cannabis, but it's almost unavoidable when I inform you about how the system works, not to appreciate how those things that are happening to the cannabis user are relevant here. And it's a very complex subject, but I think if you'll follow the teachings, not just simply of what Einstein said here about how you have to learn about it, but in particular, this particular researcher is regarded as the father of cannabinoid medicine. Raphael Mechoulam is at Hebrew University in Jerusalem, and he's the individual who in 1964 was the first to identify not simply the chemical structure, but the biosynthetic pathways of the plant's primary and actually only psychotropic chemical, THC. But then a much more important discovery was through Mechoulam's labs in the early 1990s. He identified the body's own ligands that THC is mimicking. It's not the other way around. The body doesn't mimic THC. THC is mimicking some of what the body's chemicals known as anandamide and 2-AG are doing. That's powerful. Dr. Mechoulam would possibly be getting the Nobel Prize if this was not as controversial. He's still alive at his later 80s and quite a notable figure, still contributing to the knowledge base. So in terms of those particular receptor systems that this affects, this is as of 2013. And if you look in the top left corner, you'll see CB1 and CB2 receptors. Their function, as I'll describe in just a moment, affects all of those other receptor systems outcome. This is work done at the Scripps Institute in 2016. It actually identified the physical structure of the CB1 receptor. There's actually two types of cannabinoid receptors designated as CB1 and CB2. I'll go into a little more detail about that, but CB1 receptors, their actual chemical structure is known, and that squiggly diagram in the middle being a receptor, if you look very closely, has a molecule in there, and that's the test molecule defining the space. The electron fields around it are what give these test molecules their ability to enact with some, but not necessarily all, of those functions that a CB receptor would do. Anandamide then and 2-AG, the two ligands, they naturally fit there in a lock and key way, but chemicals that fit that receptor need not resemble exactly that lock and key. When you look at THC as a molecule, it doesn't look anything like the anandamide and 2-AG, but they're all lipids, and that's key. The other botanical medicines that we generally think of and know about are alkaloids, and they're easy to separate out biochemically. It took into 21st century science to really understand how to work with these lipid receptors. The receptor itself, and this is a beautiful picture from a company named Phytex, are shown here. And I'd like to point out something on the slide that I don't want you to miss. On the bottom here, this is anandamide, and this is 2-AG. Normally, when we think about synapses, we're thinking that messages go in one direction. Even in terms of spinal afferent and efferent pathways, we're sort of taught this in medicine and medical school. Well, the endocannabinoid receptor system does something very interesting. What it does is the body's own ligands are produced on the postsynaptic surface and then go retrograde to affect whatever is being released from the presynaptic side. So every single synapse in your body has a little feedback loop that we're generally not taught in medical school. The reasons for that have nothing to do with an insidious plot to keep doctors dumb. It's part of the pragmatic way that we have curricula in schools teaching for something that's going to be tested on, which is the national board process for licensure. And you can imagine what's not asked about on the national boards being a federal type of a level thing because it has no known medical use. But nevertheless, this is relevant. It's the reason I wanted you to know about this particular mechanism, because it's not part of general education. This feedback loop then becomes a very unique pathway, and it affects this is the CB receptor here. They're found on the periphery of the presynaptic side, and yet their actions, and these are a typical class A G protein coupled receptor, that affect then whatever is being released from that particular synapse, whether dopamine, serotonin, acetylcholine, everything is affected through that system. And it does so in subtle ways that constantly keeps your body in a state that is called homeostasis, balance. Balance in nature is critically important. It relies on an animal, you, responding to a certain natural stress, whether it's a disease or something else. Your body has to stay in equilibrium, or what happens when organisms become out of balance with nature? They usually become extinct. So those particular functions then can be seen on this graph that would represent what is otherwise known as positive regulation versus negative regulation. And in fact, the activity of these receptors then can boost the activity, it can oppose the activity in a negative way. Overall, you can think of this as attenuating the normal flow of signals that go through your body at all times, and it's everywhere in the body. This is ubiquitous. Negative regulation then, in a comparable way, balances out from that side, and these are all known functions. This is not research potential for the future. These are understood fairly well. So the ubiquitous nature of this really plays into how does the brain communicate with the rest of the body? You have holistic docs who have been trying to figure for years, well, what's the brain-gut connection? It's the endocannabinoid system. How does the brain hormonally connect and make those changes? Endocannabinoids. But we know more about what goes on in the brain, which is where most people think about what are called CB1 receptors, brain and nervous system. And so this is the area in the brain where you can see CB1 receptor involvement. Obviously, you have issues concerning movement, judgment, reward, coordination, sensations, and vision from people you know who would have THC impacting on CB1 receptors. But the key point I want to bring out is right in the middle, the amygdala and the hippocampus in particular, memory. Cannabis is a performance degrader. Loss of memory is not always that bad, and we'll go into why later, but that's part of the key I wanted to point out about where these receptors are in the brain. So at this point, I'd like to try to give you a clinical model to have an understanding, not so much about THC, but again, about the natural receptor system and what it does. Raphael Mechoulam, the father of cannabinoid medicine, is not the most frequently cited researcher in the world. That person is Vincenzo Di Marzo, an Italian researcher who back in 1998 said that relaxing, eating, sleeping, forgetting, and protecting, those 5 things, might be some of these messages. So I'd like to work on just that phrase there for a little bit and put it in clinical context for really what it means. And when I do, I think you'll have a fairly good understanding for why people who use cannabis seek it for those reasons. But with the endocannabinoid system, I'd like you to think of it as being something of relevance from conception right through death. And when you look at it that way from the receptors themselves, again, I said there's 2 types, CB1 and CB2 receptors. Those CB1 receptors I'd like you to think of in context with 4 of those 5 criteria: relaxing, eating, sleeping, and forgetting. Well, from conception on, obviously, you know how important then eating and sleeping would be. So here we have something obvious, and it's not about munchies. That's what people think about when they think, oh, cannabis, it makes people eat a lot of chips and, sit around the TV screen. No, it's essential. It's essential from conception on, and those are CB1-mediated impulses, drives, and things that keep the creature in balance in a living state. The next thing I'd like to talk about after eating and sleeping, though, is actually the relaxing part. Because to recover, it's essential that the body has time, and the brain, to relax. So this guy just looks like he's chilling. I don't know what he had before sitting out there. He looks very comfortable, but it's essential to recover from life's relentless stressors. This is naturally, it's built into you. You know when you're there. You probably have the sense for people who have overall a healthy endocannabinoid system. They just know how to recover and exist with nature. It's the forgetting part that is actually fascinating to me in this sense, because forgetting in this way is not simply an inconvenience when you forgot what you should have known that the boss said the day before or what was on a given test. It's actually essential for survival. And that's where the connection of forgetting as it relates to pain and even pleasure, and we'll go into that just for a moment, seems to me to be fascinating, because cannabinoids selectively determine what's remembered and what's not. And if you think about it, should a woman who just had a baby remember the details of that delivery, as painful as it might be? If it were so, we might have no need in our language for the word brother or sister. We'd all be only children, okay? But there's a comparable side to this in terms of pleasure. And this is rather important, because a healthy endocannabinoid system enabling someone to forget extremes of pleasure, in fact, may be at risk with people with addictive disorders, PTSD, an inability to forget those kind of unpleasant things is one thing, but addiction and constantly seeking out, not rejecting things that you would for pain, but seeking out things that are pleasurable, may also be part of this system that has critical relevance in personality. We've all had different experiences in life, ranging from what we can tolerate or not, and things we find painful or pleasurable, and we all live within those safe parameters. There are several hundred chemicals circulating in the brain that look very similar as far as the lipids to anandamide in particular, and I can't imagine that they're just there because God put them there for fun, but this is potentially an area where we can know some more about the biochemistry of personality. It's been very elusive, and the thought that this may be at the core of it, to me, is fascinating. So CB2 receptors then are different. We know far less about CB2 receptors, and yet for me, I find them more fascinating because they're there to protect. And what does that mean? When DiMarzo mentioned that, he knew that CB2 receptors were qualitatively and quantitatively different because they're genetically in you, they're there, but they show up in response to a disease. And they show up right where you'd expect that disease to show up. It could still be in the brain. Parkinson's patients, their substantia nigra lights up, and other places in the body. But what those are doing, they're responding to a disease. The location of where most of these CB2 receptors are abdominal, in a very similar distribution and cell lineage to the immune system. So the immune system then is responding to protein invaders, a bacteria, a virus. That's one way we deal with those types of insults. This is the system that deals with a disease when it shows up. How does the physiology need to compensate in order to live with that disease? Why is that important? Because I've just described to you the body's inherent mechanism that allows a disease to become chronic, naturally, without other medications. So think about the potential for research and development of that mechanism of action that's now appreciated. So where's it of key use? Well, obviously you have CB2 receptors I show balancing on a little triangle there, the delicate balance that we have in life, especially as we get older. Off balance, again, not consistent with life. And it seems that that protective mechanism is what's at bay with most of the people who are using it, especially older people now who are finding certain elements of relief, including anti-inflammatory things. So this is a quick example also on how the mechanisms here affect inflammation. This is known about, and it brings us to a great point to summarize things up here for a take-home message, since I'm right at 40 minutes. The take-home message here, and from that insidious little joint there with the fumes coming up that looks somehow enticing, is that it brings up that this is really a temptations indulgence in a sense, and it offers choices. And those choices then if you look at the way the morphs into the genie that gives you those wishes, the first two are the ones before the third one that's the gotcha one. Well, those choices caution us to be careful what we wish for the same reason that I started, because science and reason really do matter. So thanks for your time. If I can help you with other questions in the panel or after, I'd be happy to answer.